Digital health can be the great enabler for improving health outcomes and clinician intervention. This discussion explores the extent of this, in addition to the difference between connecting and integrating, and the lessons learned from implementing sustainable and successful interoperable digital health solutions. This is session 8 of the Talking HealthTech Winter Summit, titled Improving Health Outcomes and Clinician Intervention through Interoperable Digital Solutions. I'll be moderating this panel, which is featuring Cathie, LaRiviere, Mackay Hospital and Health Service Manager for Virtual Health, Dr. Monica Trujillo, Chief Health Officer at Telstra Health. Monica's advancing patient-centred care and safety and improving quality outcomes through the adoption of digital technologies, clinician leadership and active community collaboration. Dr. Vlad Matic, Executive Clinical Services at Goondir Health Services, where he's responsible for the clinical governance and all services at Goondir Health Services at the Dalby, Oakley and St George and mobile medical clinics. William Grant, Virtual Care Business Lead at Telstra Health, where he's responsible for product, vision and strategy, the number of products in the Telstra Health Virtual Care portfolio. Before this session, we ran a poll and we asked, what's the biggest payoff of having more interoperable healthcare systems? 55% of respondents said better health outcomes. 30% said improved patient experience. 9% said less pressure on clinicians, and only 6% said reduced costs on the system. Let's go to the panel and see what they have to say. I'm moderating this panel. I'm not throwing to anyone, so I need to make sure I pay attention to that one. No, I've been looking forward to this one, so I shouldn't kick myself off. I'm going to bring everyone on to the middle there. Yeah, look, interesting results from the poll as well. No surprises, I guess, in terms of health outcomes. Interesting from those that responded, didn't place the immediate priority on the cost side. But let's dive into it a little bit more. We've got 45 minutes to kind of unpack, or 40 minutes now to unpack this one a bit. I want to go around to the panel firstly. I might start with Vlad. Introduce yourself, how you're connected to this concept of the delivery of virtual care, and then we can unpack it a little bit more. But we'll give Vlad the mic first.
Thank you very much. Good afternoon, everybody. And thanks for joining. My name is Vlad Matic. I'm a GP and I'm the Executive of Clinical Services at Goondir Health Service, an Aboriginal medical service centrally located in Dalby, but with clinics at Chinchilla and Oakey and St George, and also a mobile medical clinic that runs around a very large footprint of semi-remote Australia. So, the topic of virtual care is probably very near and dear to us at Goondir and to me as a clinician. And I must say I was surprised by that poll, because I would have said efficiencies and reduced costs would have been up there with patient health outcomes, very much so. I mean, if we really reflect on it, we don't have a shortage of clinicians. We have a shortage of clinical output from the clinicians we have, because we take a whole bunch of really intelligent people, send them to university, and then ask them to spend the rest of their working lives filling out bits of paper. Yeah. When machines can do it all for us. So that's why interoperability and virtual care, and indeed the computerization of healthcare is, I think, probably the main game.
Yeah, I can't wait to hear a bit more about how that's applicable to you on a day-to-day, Vlad. But we'll go to Cathie as well. Cathie, give some perspectives, fill some colour about you and virtual care.
Mute. Yeah, hi. So I'm the manager of virtual health for the Mackay Hospital and Health Service. I've been in this role for about 9 years, and we've built a small team now that I lead to deliver the virtual services in Mackay. I'm a bit like Vlad. I thought that the cost was pretty important too, because things like that really do matter in terms of being able to scale up services and deliver more services to more people. Just a bit about Mackay. So Mackay's a health service located about halfway up the Queensland coast. We cover an area of about 90,000 square kilometres, about the size of Hungary actually. And Yeah, and we have 8 communities that we serve. The Mackay Base Hospital is our regional hub centre hospital, with most of our specialist services running out of there. And the other 7 communities range from coastal communities like Proserpine and Bowen and the Whitsundays, right through to really small little mining communities out in the middle of the outback. So we service a very vast, diverse population with many needs. And it's been really important for us to harness the technology of virtual care and models of virtual care for us to be able to ensure that we can have a good reach across all of that big area and accommodate the needs of that population really well. So we're really well placed as a sort of medium-sized health service to be able to trial things and do things quite reasonably easily, not easily, but reasonably easily compared to, you know, huge populations. So yeah, it's been a great learning experience, and we've we've done it quite well, I think, quite successfully.
Yeah, I'm keen to learn a bit more about how you tie some of those systems together to this point around interoperability to deliver those outcomes, reduce the costs and everything. But Monica, tell us a bit more about you and what you do.
Pete, I made it to Talking HealthTech.
That's all that matters. You can write it. These days you can put it on your LinkedIn profile, I hear. So it's like a little badge.
Oh, no, it's super exciting.
Long overdue. Long overdue.
It's super exciting to be here on behalf of Telstra Health, as everyone saw in the video. It's a really exciting time to be in Telstra Health. We cover a large amount of the healthcare system, and our aim really is to get it all connected to each other, to talk to each other, to make it all work together. I find interesting the results of the survey as well. For me, priority is the patient experience improved with good health outcomes. Of course, we'll have better costs and better outcomes, which is all about value-based care. So I think it was because they only could pick one, and perhaps they went for that one and they couldn't rank.
Look, I wouldn't base a PhD or a research study on that particular survey, on the sample size that existed, but good conversation started nonetheless.
But it's really interesting because the previous panel was talking, can Australia lead? Australia can most definitely lead. We have some great big challenges on the remoteness, the rural, but then the size, we're able to do it. I mean, Australia's the size of Texas in terms of population, isn't it? But so broad, and some of the harsh conditions of climate, the distance. Cathie said she's halfway in Queensland. But if you think about hours, that's like, how many hours do I have to drive to get there? Really, at least 10, 11. So it's an interesting time to be part of it. We're Australia's largest digital tech provider, and it's super exciting to be here because we have real outcomes of Australian examples.
Yeah, no, great. Keen to learn a bit more about those. Will, over to you.
Yeah, hi everyone. I'm Will Grant. I lead the virtual care side of the business within Telstra Health. So Monica's given a good overview of what we do. When I was reflecting on my time in virtual care, it's been, I think, close to 17 years, which sounds like I'm getting old now. So 17 years ago, I think we came across a device that was actually in the UK at the time, where we had this device that could measure, patient obs and go send it to a clinician, and that was, super exciting. Everyone's going to say this is going to change how we're going to deliver healthcare, and then that probably started the next 15 years of pilots and projects. And what's the saying? There's more pilots in healthcare than there is in Qantas. So over the last 15 years or so, we've seen some really good projects and programs occur within virtual care. And what's actually had to happen is a pandemic has come along and enabled healthcare organisations to go, is there a better way of doing things? Is there a way that can improve the patient experience? Is there a way to reduce, or improve efficiencies, reduce potential costs, and also increase capacity, as well as keeping our patients and also clinicians safe, during the pandemic. But then how do we take this forward? And that's probably the more exciting place we're at now with virtual care as a whole across the country and even globally, is where does it now go? And there isn't a question now on, oh, is this feasible? Does the technology work, or what's the service model look like? It's more a case of how do we actually pilot it for our organization and how do we scale it? Because we know there's a benefit. We know the patient expectations and our clinician expectations have all changed. And they're all demanding, a new way of delivering. So really exciting time to be involved in this whole space of virtual care.
Absolutely. And, let's unpack it a little bit more with Vlad, who's, seeing this on a day-to-day, delivering care in a virtual means, walking the talk. Talk to me about what it actually looks like, systems connecting to each other and some of those outcomes. And yeah.
Sure. Specifically, our experience has been with a virtual care setup. So it's basically a tablet that's Bluetooth to some measuring devices, and it resides in people's homes. People are trained. They take their own readings. They'll take their own blood pressure. They'll take their own blood sugar patients, and all of that is then fed back and in currently working on fully integrated with our patient information software back at our clinics. So that's the holy grail of healthcare, a single source of truth. And I'm talking about eliminating the human processing time. So if somebody sends me a PDF of a person's results, I then have to use human time and human effort to transpose that and type that into the requisite fields in my patient information system for that to be able to be visualized graphically or to see trends over time, to be able to be extracted for the purposes of data collection, for report purposes and so forth. So the elimination of that human processing effort, to me, is the ultimate goal. Now, I'm sure that nobody enjoys going to funerals, but I have bought the number one ticket for the funeral of the fax machine, and I'd like to have everybody come with me, because I think health is probably the last industry that still uses them, and it's basically flat data that has to be reinterpreted, handled multiple times. It just seems like a complete waste. And if I may, what I'd like to say is, in the previous session, we were talking about patients and their data and so forth. So having been a clinician for 3 decades, I think it's fair to say that 3 decades ago health was something we did to people. I think we're currently doing health with people, and I hope that in the future that patients actually drive their own healthcare and we assist them to drive that healthcare. So I think it's the democratization of healthcare. I think it's the empowerment of the patient, and I think it's the elimination of inefficiencies for clinicians and systems.
But a fax is impenetrable, Vlad. It's impenetrable, they say. If you Google how to hack a fax machine, there are millions and millions of pages on how to do it. So I think it's funny that you take this view, and like you say, it's not like it's convenient information that's in nicely put fields. It's like I still visit clinics where it's literally rolled in it. So anyway, that's there's a lot more to that. Let's not sidetrack too much. No, that's on point. It's yeah, if you need tickets for that one, I'll be front and center.
Will that be a virtual funeral?
I hope so.
Can you send the tickets out by fax at the level of irony?
Don't worry, Monica, I'll fax you the details.
Yeah. Hey, Cathie, you mentioned that the virtual team has been established for 9 years. That journey, what's that been like? What was it like 9 years ago compared to now?
9 years ago, I was appointed to a role as a Telehealth Coordinator, and it was the first time that telehealth had been even really telehealth was the traditional video conference to a patient at another location, done by a few willing clinicians sort of off their own back, and we didn't do a lot of it, but we were still one of our doctors here was quite advanced at the time, Dr. Michael Williams, and he was a leader across the state, in fact. So we were lucky to have him. So that was where we started. And then over the years, I've been able to slowly build up a small team of now 5, and we've become kind of a centralised unit where we lead the development of the programs and the projects, and then provide the ongoing tech support, etc., to keep those going over time. So our team's been able to, over that time, build up a really high level of expertise in the technology and the sorts of workflows and the way we can work with our clinicians to co-design models of care and workflows that can kind of allow us to incorporate virtual into their routine practice. So it's not about seeing, often people will talk about telehealth like it's some standalone specialty all of its own. And it's like, well, no, it's actually just a delivery mode. It's a way of a modality of interacting with people, and you can incorporate it. If you look at a patient flow map, which I've actually created a patient flow map now that shows all of the touch points and connection points where a patient might have access to health services, whether it be in any domain of emergency, inpatient, outpatient, wherever, and it might be at any location across our 8 facilities. You can identify at every one of those connection points where you could incorporate some modality of virtual into that interaction to beam a specialist into them in real time, at a point of need in an emergency situation, or to link them up with a specialist at a tertiary centre many, many thousands of miles away for a regular specialist appointment, or to hook them up in an inpatient setting in a remote patient monitoring program. So there's all sorts of ways that we can incorporate the technology into what we do clinically every day, without necessarily diverting or having to go through some arduous process. So it's about having a seamless way of doing that allows the clinicians to know that they don't have to do much. It's just about, this is actually really easy to do. And once they realise that, they're on board and they go for it.
Yeah, look, that's an interesting point, isn't it? I think about my own experiences as a patient crossing different health systems from the primary care to the hospital space. And you think about those that need to go from care in the allied world, like we heard in the previous panel, or in disability. That connectivity often doesn't exist. You see buckets of bits of paper being transferred around, like physically carried into locations, and things starting again. So there's, Monica, would you say, like we talked a lot about the benefit from the clinician's point of view, that, with systems that are more interoperable and have that connectivity, there's a benefit from the clinician, but obviously from the patient side, there's no doubt benefits there too, right?
Yeah, I've been thinking about this, and, Cathie just articulated really well in that virtual care is real care. And that whole concept of the labeling sometimes of the word virtual almost puts it on the side, like, no, this is not real. But I've been mulling through this recently, and as I was listening to Cathie, and, I was going, absolutely, this is real care for patients. Virtual care is real care. And if we move away from the concept of this is a nice to have, but this is a real model of care that is giving people access when they didn't have access before, is giving them ongoing monitoring, is allowing them to be at home to monitor their own results. And then we have 98% of the patients being satisfied with the care and would continue to do it. We have a model of care that we really have to consider as a real model of care. And I think that Cathie articulated so well. But, it's like hashtag virtual care is real care. I think today I got a call call from my GP. She needed me to go and get some meds today. She sent me a token to my mobile. I went through, it was done to the pharmacy. I was given the meds straight away. And I think, wow, how lucky am I to be able to have that done within, an hour or so. But if you think about looking at the different, where people live, the determinants of in the middle of looking after young ones. This is actually offering people real alternatives to not completely take a family upside down, take them where they are, being able to access care, being able to get the medication as soon as they can, being able to stay with, little ones or elder ones, or looking after their shop or their station or wherever you are located. This is real care. So this is real care results for community that, that use technology, that have accepted it, that have said, I want to continue to do it, and that we're seeing real impacts on caregiving and receiving of care. So it's absolutely real. When we see it, we're making this an equalizer of care, and be able to access people. When you think about each one of us, when we've been receiving care, you're in a really vulnerable situation. You want to be there with someone if you don't speak English, if English is not your first language, or if you have small one, whatever situation it is, it really equalizes and allows you to have an opportunity to have someone with you, or to not travel, or to have an ongoing monitoring. So I really wanted to hone down to the virtual care is real care. We have real experiences, we have real people having access to it, and not diminishing, like we see some in North Queensland are going again, trials, people being moved into trials through virtual care and teletrials, and being able to access clinical trials where before it wasn't even accessible.
Yeah, that's an interesting dynamic too. I'll go to Will soon, but I wanted to go back to Vlad and Cathie for a second, just on that one in particular, because to your point, Monica, it's all in framing, isn't it? And prioritization from a patient's point, but also for the clinician too. I think about my own examples where a doctor might say, oh, we'll just settle for a virtual consult. Is it okay if we just do virtual for this one? But lucky you, hey, you could come and see me in person, because today is your lucky day. Vlad, from your side, do patients see the virtual as a trade-off? Like, unfortunately, you'll have to do this one virtually. Or I know from my own perspective as a parent of 3 kids, being able to do something virtually is almost a value add. It's being like that. If we could do this virtually, I would pay extra if I was paying for something. Whereas others might be like, well, I guess if I have to. How have you seen it on I don't want to make assumptions from my own perspective. Patients on a day-to-day, how do you see it?
Well, when we first rolled out the virtual care monitoring at Goondir, our null hypothesis was that we would actually decrease physical visits to the clinics. As we've found, that the number of physical attendances to the clinics per year have actually remained steady, and this is like an augmentation of that care. Now, I think a point we might not have covered as yet is the quality, or if you like, the veracity of the care. And what I mean by that is, if, as the national data tells us, the average Australian attends their GP 4.6 times a year, let's call it 5. That means the clinician is working off 5 sets of readings. If, however, a patient takes 1 reading per day every day for a year, that clinician is making a clinical judgment based on 365 readings. So there is a richness, a depth, an ability to analyze a far greater, when N is greater, the accuracy is greater. So, and I think, but it hasn't removed care. It hasn't supplanted care. It has, however, saved people unnecessary trips. It's also empowered patients because they see their own data. They're generating it. They can see the trends as well. There's almost like a biofeed. There's an engagement with healthcare because they're contributing on a daily basis. It's not like, oh, yes, I'll pop into the doctor and get a script. It's like I'm actively empowered to act in my own healthcare on a daily basis. So we've found that the uptake is good. We've found that visits are not reduced. Patient satisfaction is high. Technical prowess. I mean, if you can do Facebook, you can do virtual care. So, if you own a mobile phone, you should be with it. I mean, it's that simple. And as I said to you, from a clinician's point of view, it's safe. It's data-informed health decision-making. And I think it's got.
No, Cathie, does
a
that
long way to
resonate
go.
with
Just
you on
use
the?
it as the poor cousin. Yeah.
Sorry, there was a bit of a delay.
Yeah,
On
totally resonates. All of that. One of my pet peeves, and has been for many years, has been the way people refer to telehealth or video, virtual, and or face-to-face. I really hate that. I never use the term face-to-face for an in-person. I use in-person or virtual face-to-face, because we're now face-to-face, are we not? And I just, they call it FaceTime, for heaven's sake. So on your phone. So, I find that really kind of, hang on a minute. you don't have to, you're in person, but you're still face to face on a virtual call. And yeah, I agree with everything that Vlad and Monica have said around the value of it as well, and what you said too, Pete, about you'd pay more. I think I've stopped using the term over the last couple of years, talking about it being across distance, as if it's something that we only do when people are a very long way away, because you might have somebody who actually lives across the road from the hospital, but they might have a disability, or be caring for young ones, or something that for them, the value of having to try and get themselves up and out and across to the hospital, if you'd have put a value on I had a conversation with a doctor one day who was telling me that being able to come and see him in person was really high value. And I just said, well, I don't know, this guy that you've just seen's driven 4 hours from Claremont to see you. He's got up at probably 4 o'clock this morning, and for every hour he spent on the road, and then he's going to spend another 4 hours going back, and you literally saw him for, I think, 12 minutes. So I'm just wondering, if he was to put a dollar figure on that per minute, what value? I reckon you're in the negatives. So, it was an interesting conversation, and it put a whole different spin on it for that particular specialist. And he sort of thought about it. He said, oh, actually, yeah, seeing me face to face for 12 minutes probably isn't that much value for this guy, given that context. So yeah, he does telehealth more now. So that's good.
Yeah, well, I think this came up in a session previous as well, is that, it's if we can bake in the ability to have patients more involved in that choice, and the ability to allow patients the choice about what's better for them, because in the end it's healthcare for them. But it's not just about clinicians and the system supporting it, it's the funding, it's all the other kind of bits and pieces that I think will have already come up in sessions, but we'll dive into that in other ones coming up too. Just on your point as well, Cathie, about the in-person versus virtual and face-to-face, we got to keep up, because in crypto Web3 metaverse land, the term IRL, in real life, doesn't mean physically meeting in person. It means not meeting in the metaverse. It means meeting on a virtual meeting. So it's not even the concept of virtual. Like IRL is like just with our human presence, like on a screen, let alone our avatars. So we'll still be sending faxes in 10 years into the metaverse. But Will, I want to go to you, because there'd be a lot of progression if we had many more Vlads and Cathies out there in healthcare. However, from your perspective, seeing it across from all of Australia in different communities, and the need that exists, how do we do this in a more scalable way to be able to enable more interoperability for these communities, patients and clinicians, to access care in a more effective way?
Yeah, well, I think firstly it's sessions like this where more people can hear about Dr. Vlad and Cathie's stories. They don't. I think the Australian community wants to share successes and also failures where they fail. And the more we can do that, the better. Because this isn't rocket science. This is you don't, and you also don't have to reinvent the wheel. So there is definitely lessons learned across the community. And when you start looking at how do we start, what do we need to look at, how do you want to scale out these types of service models, is kind of the last 10 minutes of what we just be talking about, is how do you embed it into your service model. And it's not differentiating between virtual care and in-person or face-to-face. It's make sure it's clinically appropriate. That's probably the main thing. The other kind of things you would kind of think about would be, if you wanted to kind of scale these types of things out, it's pretty obvious. But yeah, integrations with systems, like Dr. Vlad mentioned this already. But we do it for particular reasons of reducing clinical risk. You do it for reasons of efficiencies. You also do it for the experience. Everyone of course talks about the patient experience, which I can talk about, but the clinician experience is just as important. They're like a super user of virtual care, and they're the ones that are going to be they're the champions. So they're the ones going to be promoting it to their patients. More and more patients are going to ask for it, but typically a clinician is going to be saying, do you want virtual care, and this is the benefits, or this is how it works, and I really think it's a great thing for you. So we've got to get clinician experience up, and one way to do that is through integrations of systems, because you don't want to be asking clinicians to do more work when they've got so much more to do already. So if we can use integration of systems to create those efficiencies for clinicians, that's awesome. And then, of course, looking at the patient experience, because if patients don't want to use it, then you've got a problem. So the patient experience is really important, so that they have really good adherence or compliance, or whatever word you want to use for it. That they take more proactive management of their own healthcare, or gives them opportunity to do that, and also allows them to be connected to their health professionals. So a lot of people focus on virtual care when they do like evaluations and research on it. Did the technology work, or was it something else? The technology is like 20% of it. It's like 25% maybe of the whole solution. When you do these evaluations and these patients are saying, oh, I love it, 95% said it's fantastic, and I'd always choose virtual care over face-to-face, and those types of stats come out. It's primarily because the patient feels more connected to their clinician. The technology is enabling that to happen. So that's why, I suppose, at Telstra Health perspective, we do the easy bit. It's the service modeling that Cathie and Dr. Vlad spoke about, of how do you embed it, how do you make it convenient for your clinicians and also the patients. And also, I suppose it might be something, I don't know if Cathie wants to talk about, but because Cathie's, for example, done virtual care for 7 or 9 years, how do you change the service models repeatedly with different technology types, and keep your clinicians engaged in wanting to make those changes? And that's quite a challenging feat.
Absolutely. And, it's one that we can unpack, and we could throw to Cathie. I see here as well, it ties into something I was about to ask, but I can see that it's on the mind of Chrissa as well, and no doubt others. The question is, a challenge that we commonly hear from patients trying to adopt digital healthcare is how siloed it is. How do we move to a more integrated system? And I guess that's tied into what we've been talking about now. But there's a lot of existing tech, and while it would be nice to be able to, rip everything out and say, here's one platform that everyone works on and start again, but healthcare needs to be delivered on a day-to-day, and it's not clean as the comment suggests. We'll start going around the room because we've got just under 10 minutes left. In terms of, from your own experience, panel, from implementing and operationalizing virtual care settings, whether it's because we've got a good mix of attendees and people listening in, because this one will turn into a podcast episode as well, those that might be creating solutions or delivering care in a virtual setting, or even receiving virtual care, that so many stakeholders within healthcare, advice for those that are undergoing a journey, whether it in a small single practice or in a healthcare system, some advice from your experiences in virtual care. So we'll start with Cathie, because you're just at the top of the screen there, and then we'll go around for 2 minutes each.
Well, yeah, okay. From a practical, operational kind of make it happen perspective, I guess there's been a few learnings for us. One is at the beginning, I kind of naively thought that we'll walk in, we video enabled every single consult room in our outpatients area and put webcams in and everything, and second screens, and we showed all these clinicians how to use the telehealth system to link up with the other sites to do telehealth across distance to our rural communities, and then there you go, that's how it works, on you go. And They didn't do it. They just went, yeah, yep, we'll do it. We're not doing it. So that was that. And I was like, oh dear. So then I realized this is going to be a bit harder than I thought, even though they knew it was good for the patients. They didn't have to travel, all those things. It was that high value thing, seeing me in person's more value. And it wasn't having the faith that delivering clinical care across a video was going to actually be real care. So we had to get them over that barrier. So what we did was we started being the coordinators for it. So we put telehealth coordinators in our outpatient areas, and they literally held their hand and they walk into the room, they dial in for them, and really the doctor just has to sit there and turn up. So that's how we started, and we just got them doing it. And once they used it, and once they saw that it actually was pretty easy, and it didn't actually turn out to be, we didn't have risk mans and clinical incidents happening, and it was all really good. So they started to use it more and more, and that was kind of getting that initial buy-in. So having coordinators, anything that's an administrative task associated with delivering virtual care in whatever system it is in or whatever domain it is in, whether it's outpatients, emergency, inpatient, wherever, that's done by an admin officer. Clinicians, only clinician. So we've made it really important that they have good coordination to support them all the way, so it's seamless for them, and that way they will play with us in that space, and engaging them and letting them be the architects of their service models. Doctors like to be creative, and clinicians, nurses too, they like to be creative. They like to have a say. What they don't like is when we plonk some technology in front of them and say, this is it, this is how it works, and you've got to press this button and this button, and then you've got to do it like this, and you've got to put this record here, and as Will rightly said, that interoperability, making it really easy so that the videos all there, the video calling or the remote patient monitoring program or whatever is all there, but they don't have to do much, if anything, or only a little bit of anything, to make sure that they can still incorporate that into what they usually do with much burden. That's really important. But giving them the say, letting them drive it. So they'd say to me, what do you want me to do now? And I'd say, well, I don't want you to do anything. You tell me what you want to do. And then we would do it from that way. So they are the architect of the design. And we've got specialists areas where we've got a group of guys who will do, we've got a different workflow and model, or a slightly different model for an individual specialist within that same specialty group, because that's the way they like to deliver their care. That's their clinic model, or the way they like to do it. So that's really important. And lastly, very quickly, having good monitoring in place. So once you've set up a program, have really good monitoring so that you can check in regularly and you can see the data and you can see how it's ticking along, and you're constantly and regularly checking in with those clinicians and those groups, because walk away from it and then 6 months later you hear a whisper that, they're not doing that over there anymore. And when you go to see them, they go, look, this didn't work so good this day, and we just got sick of trying, so we just stopped and we've just reverted back to the old way. They don't necessarily come and yell out and say, hey, something's not right, come and help us with it. You need to constantly be going back and reminding and supporting. So having that good coordination, a centralised coordination, or some method of at the elbow tech support, someone they can reach out to, building those relationships so they trust you to let you know when something's going wrong. That's been critical for us, and I think that's been a big improvement to the way we started, and that's how we mean to go on.
Oh, look, super valuable insights and reflections, Cathie, because it's rare to hear from a larger health systems point of view how to effectively do that at scale, and something that we need in other areas too. So very excited to share that with others. But Vlad, from your side too, from your own experiences firsthand.
Okay, I'd say that change will occur when the price and the risk of doing nothing is less than the price and risk. Sorry, when the price of doing nothing is great and the risk of doing nothing is greater than the price of doing something and taking a bit of a risk. So I actually say to people, jump, have a whole list of assumptions, and then be prepared to be completely proven wrong. And that is the price of innovation. I think that's the inherent courage of any innovation. I think bring your clinicians along, bring your patients along, explain, converse, be prepared to feedback. It's just sort of PDSA over and over and over again, and just refine, capture your learnings as you go, evaluate as you go, and once again, just the clinical governance of any system is probably as important as the technical aspect of any system. So I think that's where patients derive comfort. I think that's where clinicians feel at peace, and then the tech can follow it behind. But too often in tech, I think we put the tech front and center, whereas it's actually the care that's front and center, enabled by the tech. So that'd be my summary of it, I think. And I noticed a comment there about RACGP saying that there's no benefit of video over telephone. Well, respectfully to my colleagues, I'd say to them, if 70% of communication is non-verbal, even 100% cues on 30% surely can get slaughtered by somebody who's half watching 50% of 70% and listening, So I think I'd like to see that data. I'd like to see how that data was generated. But I really do believe that I think we're ready for it. I think we've got no option. I think the workforce situation, the tyranny of distance, the inefficiencies, everything else, I just think we've got no choice. So let's embrace it. Let's run with it. And if we have to make it up as we go, so be it.
No, perfect. Love it. Monica and Will, I haven't left you much time. We need to wrap in a minute, but I think it's really important that we had those perspectives of those, dealing on it firsthand. Any final thoughts from you, Monica?
For me, going back to virtual care is real care, and we do have data, and Cathie was mentioning some of it, but we do have data that it does significantly reduce 51% of all-cause readmission rate for adults within 28 days in the hospital and the home, remote patient monitoring, with reduction in ED and savings, readmission and bed days. So whatever program you do, I mean, the team of Mackay has been measuring their outcomes. She's spot on. You have to measure like any other program. It would suit a cohort, pick your cohort, measure, and see the outcomes, because virtual care is real care.
Love it. And Will, when you come off mute, any final thoughts?
I thought I was going to do that. Only final thoughts would be, I'm so disappointed I haven't come up with a hashtag as Monica has. So she got me there. And the only other thing I'll be is, I think the difference is also having a clear strategy. What is your strategy for the organization, and how do you take it in and embed it in? And then you can have that as your North Star and align to that over the many years, because it will change year in, year out. And you can change with it with your strategy. That's about it.
Love it. Well, look, Vlad, Monica, Cathie, Will, appreciate the discussion. Good engagement in the chat too. Encourage you all as speakers to jump back into the Hop-In platform to respond to any new ones that come up. Thanks for taking time out of your busy schedule to contribute to this really important conversation.
Thanks, heaps.
Thanks a lot.
Bye-bye.